Welcome to today's video where we'll delve into the crucial topic of ventilator graphics. Ventilator waveforms offer an invaluable window into the intricate workings of the respiratory system, serving as a vital tool for clinicians in understanding a range of pulmonary conditions. Today, we will introduce a structured, step-by-step approach that clinicians can employ to scrutinize these ventilator waveforms. This approach is applicable to patients on either pressure control or volume control ventilation. Keep in mind that understanding a specific pathophysiology, such as increased airway resistance, does not necessarily pinpoint the underlying pathology, like a kinked endotracheal tube or bronchospasm. For the sake of clarity in this review, our discussions will be based on a simplified one-compartment lung model with a linear response to a range of tidal volumes. Let's get started. Equation of motion describes pressures involved in ventilation. PVent, ventilator pressure, positive pressure. PMUs, muscle pressure, negative pressure. These pressures work to overcome intrinsic resistance, elastic response, and PEEP. Elastance and compliance. Elastance is the inverse of compliance. High elastance indicates poorly compliant lungs or a stiff chest wall, leading to increased elastic load. Direction of airflow, determined by the gradient between the left and right sides of the equation of motion. Seen clinically as changes in airway pressure and flow waveforms over time. Step 1. Assess expiratory flow waveform to generate a pathophysiologic hypothesis. Expiration mechanism. In pressure and volume control ventilation, cessation of flow from the ventilator initiates expiration. Expiration can be passive or active, depending on patient effort. Passive expiration reflects resistive and elastic loads. Expiratory flow waveform shows exponential decay to baseline. Useful for hypothesizing intrinsic lung issues. Assessing expiratory flow waveform. Expiratory time constant is a function of resistance and compliance. Time constant is time to exhale 63% of lung volume. Prolonged expiratory time constants indicate high lung compliance or elevated airway resistance. Conditions like COPD, mucus plugging, or kinked endotracheal tube can cause this. Short expiratory time constants indicate decreased lung compliance. Conditions like ARDS, cardiogenic pulmonary edema, or chest wall stiffness can cause this. Active exhalation. Patient effort can affect expiratory waveform. Upward flow movement may indicate a failed trigger or premature cycle. Auto-PEEP occurs when incomplete exhalation leads to retained air, common in high compliance, increased resistance, or large tidal volumes. Text, auto-PEEP, equals, text, total PEEP, text, applied PEEP. Expiratory flow limitation occurs from dynamic small and distal airway collapse. Causes auto-PEEP and observed in conditions like COPD, congestive heart failure, and obesity. Secretions. Presence hypothesized when sawtooth expiratory flow is observed. Step 2. Assess inspiratory flow waveform to corroborate pathophysiologic diagnosis. Inspiratory period. Interaction between the ventilator and the patient's lungs. In volume control, flow is controlled. In pressure control, pressure is controlled. Volume control ventilation. Square waveform. Quick rise in flow, remains constant until target tidal volume is reached. Descending waveform. Decreases linearly after maximum flow. Pressure control and pressure support. Characteristic decelerating waveform with exponential decay. Influenced by patient effort, airway resistance, and pressure gradients. Diagnosis corroboration. Increased compliance or airway resistance can lead to decreased peak inspiratory flow. In conditions like COPD, flow may not reach baseline due to slow lung inflation. Time constants. Prolonged time constants in conditions like bronchospasm can lead to reduced tidal volumes. Short time constants indicate low compliance states, such as decreased insufflation times. Patient effort. A linear or upward concavity shape suggests patient effort during inspiration. May require adjustment in inspiratory pressures or flow to manage. Other considerations. A leak or increased flow from lung recruitment shifts the waveform upwards. Step 3. Assess inspiratory pressure curves to confirm pathophysiologic diagnosis. Volume control ventilation. Flow is the independent variable, pressure is the dependent variable. Initial pressure rise indicates resistive load. End inspiratory pressure reflects elastic load. Pressure control ventilation. Pressure is the independent variable, flow is the dependent variable. Plateau pressure, P-plat, calculated in both volume and pressure control. Assessed at end inspiration with inspiratory hold maneuver. Indicates lung compliance and airway resistance. Peak inspiratory flow, PIP, and P-plat. Escalating, PIP, P-plat, suggests resistive pathologies like mucus plugging or bronchospasm. Increased P-plat suggests conditions like ARDS, pulmonary edema, or pneumothorax. Auto-PEEP, measured with static expiratory hold maneuver. Indicates elevated plateau pressures and increased PIP, P-plat. Stress index, derived from airway pressure time curve. Assesses compliance by quantifying recruitment and overdistension. Compliance and pressure curves. Linear slope indicates non-injurious alveolar distension. Downward concavity suggests recruitment, upward suggests overdistension. Decelerating flow waveform, reduces effects of increased airway resistance. Increases inspiratory time unless flow rate is increased, leading to reduced expiratory times and potential auto-PEEP. Elevated pressure at end inspiration, indicates either poor lung compliance or exhalation during mechanical inspiratory breath. Inspiratory patient effort, pressure waveforms show inspiratory pressure moving toward baseline. Phenomenon of flow starvation occurs if pressure drops below baseline. Step 4. Identify the triggering source. Triggering source, triggered by patient effort or time. Change in pressure or flow can initiate a breath. Identifying type of trigger can reveal pathologies. Triggering asynchronies, failure to trigger, no ventilator response to patient effort. False trigger, ventilator response without patient effort. Failure to trigger, ventilator senses negative deflections in circuit pressure or airflow as patient effort. Inadequate respiratory effort may fail to trigger if alveolar pressure is high, e.g., auto-PEEP. Flow triggers may reduce work of breathing but are not foolproof. False triggering, auto-triggering, stimuli unrelated to patient effort cause ventilator to deliver a breath. Possible causes include cardiac oscillations, tubing condensation, chest tube leaks, sensitive triggering settings, or external vibrations. Diagnostic measures for auto-triggering. Fix circuit leaks or remove external vibration sources. Switch ventilator to pressure trigger mode for diagnosis. Clinical implications. Cardiac oscillations manifest as rapid distortions in expiratory flow and pressure waveforms. Auto-triggering can confound the clinical verification of brain death. Step 5. Identify the time between inspiration and expiration. Desynchronies in cycling. Mismatch between ventilator's set inspiratory and expiratory times and patient's actual breathing cycles. Types of desynchronies in cycling. Premature cycling occurs when patient's inspiratory effort exceeds machine's set time. Results in stacking breaths, leading to large tidal volumes and increased pressures. Solution. Extend machine's inspiratory time. Delayed cycling occurs when set inspiratory time is longer than patient's natural inspiratory time. Causes exhalation during a machine-delivered breath, risking barotrauma. Solution. Shorten machine's inspiratory time. Early or reverse trigger. Reflexive inspiratory effort follows a machine-triggered breath. Termed entrainment, when recurring. Occurs during transition from inspiratory to expiratory phase. More common between intense and mild sedation phases. Management strategies are uncertain but may involve adjusting respiratory rate or sedation. If you found this information valuable and would like to stay updated with the latest insights in critical care medicine, we encourage you to subscribe to our newsletter. Your subscription will provide you with access to a wealth of knowledge, research updates, and expert opinions directly in your inbox. Don't miss out, subscribe today.